Hey everyone, today we're diving into a crucial and serious topic of the 10 complications of severe malaria. Malaria is a life-threatening disease caused by Plasmodium parasites, transmitted to people through the bites of infected female Anopheles mosquitoes, leading to high fevers, chills, and flu-like illness. While many cases are treatable, when the infection becomes severe, it can quickly escalate and damage major organ systems. In this video, we'll walk through the top 10 dangerous and often fatal complications that can arise from severe malaria, explaining why timely diagnosis and treatment are absolutely vital. Severe malaria, driven primarily by the Plasmodium falciparum parasite being fulminate, causing systemic failure across the body. The most critical risk is cerebral malaria, severe anemia, pulmonary edema, acute kidney injury, hypoglycemia, shock, metabolic acidosis, and other complications like jaundice and abnormal bleeding, with all these risks heavily correlating with a high concentration of parasites. Given this terrifying range of potential outcomes, we are now going to look at each of these complications in detail. Cerebral malaria is driven by Plasmodium falciparum parasites, modifying red blood cells with proteins-like molecules, causing them to stick to the brain's microvasculature in a process called sequestration. This clogs blood vessels, leading to cerebral hypoxia and ischemia. The sequestration and resulting oxygen deprivation activate the endothelial cells, causing the release of pro-inflammatory cytokines which damage the endothelium and disrupt the blood-brain barrier. This barrier failure allows fluid to leak into the brain, causing cerebral edema and increased intracranial pressure, ultimately leading to neurological dysfunction and coma. The pathophysiology of pulmonary edema in severe malaria is primarily that of acute respiratory distress syndrome, driven by an overwhelming systemic inflammatory response to the Plasmodium falciparum parasite. The core mechanism is a cytokine storm that severely damages the alveolar capillary endothelial barrier in the lungs, dramatically increasing its permeability. This causes a protein-rich fluid to leak rapidly from the blood vessels into the air sacs, severely compromising oxygen exchange. Contributing factors include sequestration of infected red blood cells, clogging the pulmonary microvasculature, acute kidney injury that exacerbates fluid overload, and other underlying comorbidities. Severe malaria causes acute kidney injury and hemoglobinuria primarily through massive intravascular hemolysis, which releases excessive cell-free hemoglobin into the blood, leading to hemoglobinuria or black water fever. This free hemoglobin is highly nephrotoxic, as its component heme generates damaging reactive oxygen species and precipitates in the renal tubules, causing acute tubular necrosis. Concurrently, free hemoglobin scavenges local nitric oxide, causing renal vasoconstriction, while parasitized red blood cells physically sequester and obstruct the kidney's microcirculation, collectively leading to ischemia and widespread kidney damage amplified by systemic inflammation. Severe malaria leads to disseminated intravascular coagulation by initiating a fatal cycle of coagulation and inflammation. Begins when inflammatory mediators and parasitized red blood cells induce tissue factor expression on endothelial cells, coupled with the sequestration in microvessels, causing obstruction and tissue damage. Simultaneously, the parasite binding impairs the natural anticoagulation system while the inflammatory environment suppresses fibrinolysis. This results in a widespread, uncontrolled hypercoagulable state that leads to microvascular thrombosis and organ failure. This massive consumption of platelets and clotting factors then switches the patient to a dangerous, paradoxical bleeding diathesis, defining the catastrophic clinical syndrome. Algid malaria is characterized by circulatory shock, hypothermia, and profound metabolic acidosis, arising primarily from the parasite's effects on the host's microcirculation and systemic response. The core pathophysiology involves sticking of infected red blood cells to the vascular endothelium, especially in the gastrointestinal tract, causing tissue ischemia and damage. This leads to severe gastroenteritis with vomiting and profuse diarrhea, resulting in critical hypovolemic shock. Furthermore, the massive release of inflammatory cytokines exacerbates shock through increased vascular permeability and vasodilation, while tissue hypoxia and parasite metabolism drive severe lactic acidosis, often compounded by a critical co-infection with bacterial septicemia. Metabolic acidosis in severe malaria is a high anion gap acidosis primarily due to lactic acidosis, resulting from a critical imbalance between lactate production and clearance. Production is vastly increased because microvascular sequestration of infected red blood cells leads to severe tissue hypoxia and impaired oxygen delivery, forcing cells into inefficient anaerobic glycolysis, while the parasites themselves also produce large amounts of lactate. Clearance of this excess lactate is simultaneously impaired because severe malaria often causes hepatic dysfunction which hinders the Cori cycle, and acute kidney injury which reduces acid excretion and bicarbonate reabsorption, creating a vicious cycle where high lactate levels quickly overwhelm the blood's buffering capacity. Severe anemia in malaria is a multifaceted condition resulting from the imbalance between excessive red blood cell destruction and impaired production. The destruction component involves the direct lysis of infected red blood cell by the multiplying parasite, coupled with substantial, immune-mediated clearance of uninfected RBCs due to splenic hyperfunction and membrane damage caused by inflammation and parasite byproducts like hemazoin. Simultaneously, the production component fails because the robust inflammatory response suppresses erythropoiesis, inhibits erythropoietin production, and disrupts iron availability, leading to an inappropriately low bone marrow response despite the life-threatening anemia. Hypoglycemia in severe malaria is a dangerous condition driven by a significant imbalance between glucose consumption and production. The key factors are the massive glucose utilization by the high burden of metabolically active parasites, coupled with impaired glucose production because of starvation, vomiting, and malaria-induced liver dysfunction. Furthermore, the antimalarial drug quinine can exacerbate the condition by directly stimulating pancreatic beta cells, causing a massive release of insulin and leading to iatrogenic hyperinsulinemic hypoglycemia, especially in adults and pregnant women. Severe malaria can lead to a host of other serious complications beyond the most common ones. These include hyperparasitemia of more than 10% of infected red blood cells infected, or an absolute count of over 250,000 parasites per microliter of blood. Severe liver dysfunction presenting as malaria hepatitis and jaundice, which can escalate into life-threatening liver failure. Long-term or repeated infections may lead to tropical splenomegaly syndrome, also called hyperreactive malarial splenomegaly. Critically ill patients may experience profound weakness known as prostration or, less commonly, a dangerous emergency like splenic rupture. Other systemic issues include hyperpyrexia, often complicated by a drop in neutrophils, febrile neutropenia. The eyes can be affected by malaria retinopathy, and some individuals may develop delayed neurological sequelae known as post-malaria neurological syndrome.